Good afternoon, and thank you for joining the Foundation's webinar titled Dopamine Agonists versus Alpha-2 Delta Ligands. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. The RLS Foundation is using Zoom webinar for this and all future webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date with the current software. If you need help accessing the live webinar on your computer, call the phone number listed on your registration confirmation email for assistance. If you have any other questions, please email clara@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Silber will answer as many questions as time allows following his presentation. After the webinar recording will be made available in the member portal section of our website on the next business day. If you're not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Michael Silber, is a board-certified neurologist and sleep specialist and serves as director of the RLS Quality Care Center at the Center for Sleep Medicine at Mayo Clinic in Rochester, Minnesota. Dr. Silber is an active member of the RLS Foundation's Scientific and Medical Advisory Board and the current chair of the Revised Treatment Consensus Committee and serves on the Opiates Committee. With a particular focus in neurology, his areas of research include the relationship of REM sleep behavior disorder to neurodegenerative diseases, drug management and predisposing factors related to RLS, and epidemiology and pathogenesis of narcolepsy with special reference to the hypocretin system. Dr. Silber, we thank you for sharing your time and expertise with us today. I now invite you to begin your presentation.
Thank you so much. It's a pleasure to have this opportunity to talk to people who either have restless legs or whose relatives or friends have restless legs, and to see if we can reach some clarity on some of these very complex issues, which are so important for anyone suffering from this really sometimes very disabling disorder. So I was asked to talk on dopamine agonists versus alpha-2 delta ligands for restless legs. Okay, the objectives of this presentation will first be to talk about something a little different, actually, placebo effects and how new drugs are developed for RLS. Then why alpha-2 delta ligands have now become first-line agents for RLS, how those drugs and the dopamine agonists should be used for RLS, and then how should dopamine augmentation be managed. So let's start with placebo effects. Well, a placebo effect is when one's doing, for instance, a double-blind controlled trial, and say half the patients are given the drug that we're testing, and the other half are given a sugar pill. Of course, it's not really a sugar pill, but it's an inert substance which shouldn't have any effect at all, and neither the investigators nor the patients know which one they've been given. Well, here's a really interesting study that was done looking at, as you can see, 84 randomized controlled trials for restless legs. And they looked not at the effect of the drug, but the effect of the sugar pill. And on the top bullet here, you see the IRLS scale from 0 to 40. 0 is no restless legs, 40 is extremely severe restless legs. And those patients who got the placebo, the sugar pill, even though they didn't know they got it, improved. And they improved by an average of almost 7 points. And even more impressively, we used a different scale called the Global Impression of Change scale, which we ask the investigator to estimate how much better the patient is and the patient to estimate how much better they are. You'll see that 46% of the investigators and independently 40% of the patients taking the placebo said they were much or very much improved. So placebo effect is a real thing. It doesn't mean the patients were bluffing or that they were confused or anything like that at all. It's a real effect. but it plays a role in how we interpret the effect of medications, both in trials and when we first give a patient a new drug. There is a tendency of the brain to want to benefit from it. So even if it isn't effective, sometimes initially there is a benefit, but it doesn't usually last. So how did we develop knowledge of the alpha-2 delta ligands, the dopamine agonists, and all new drugs we develop? Well, often it starts with basic science studies. Somebody works in a laboratory, test tube work, they investigate chemistry of the brain and say, wow, you know what we found here, this particular substance in the brain seems to work on pathways. Maybe this might be helpful for restless legs. Or alternatively, it's just a clinician working, struggling with some patients with hard to treat restless legs, says, let me try drug X. And it seems to work. So they then do a short series, we call it open label, because the patient knows they're taking the drug, the investigator knows there's no placebo, and they write up an article of 10 or 15 patients and say, we've had wonderful success, here's a new treatment for restless legs, it works perfectly. Well, from what we've just learned about placebo effect, I tend to be skeptical when I read these reports. It doesn't mean we don't pay attention to them, but that's not sufficient because you worry that some of this apparent wonderful benefit initially might be placebo effect rather than real. So when we get these studies, it's important wherever possible to progress to double-blind controlled trials where we do a proper trial comparing to a real placebo and see if the drug works better. There are many small trials, best of the large trials over multiple centers, but they're so expensive and really they can only be done generally if the drug company producing the drug is willing to sponsor it. Then when we've real proof that it works, then we want to see how does it work in the real world, because you know a double-blind controlled trial is very well done, but it is artificial. It's done under very controlled circumstances, and those of you who may have participated in some such trials will know this. It's very controlled. So then we want to see large, real-world, long-term open-label studies. We don't mind there's no placebo at that time because we know it works. But what happens when we really use it in the real world? And most of the drugs we're going to talk about today have gone through this process. But I thought it important to just review this, especially when you read a report, this new drug may be available. Here's a series of 10 or 5 patients tried on it, worked perfectly. That it may be good, it may be the future drug, but regrettably, sometimes it isn't. All right, so I want to really base this talk on 2 patients. The first one is a 42-year-old woman who presents with untreated typical restless leg syndrome. Symptoms started 5 years before, but have increased in severity. They now delay sleep onset by 1 to 2 hours every night. And when she does fall asleep, she wakes at 2 a.m. 3 nights a week and is up for another hour or 2, all with restless legs. She doesn't have symptoms during the day, and her physician measured all the iron measurements. They're all normal. And I'm sure, regrettably, this scenario is very familiar to many of you. So the question is, here now, March 2023, what medication should we start this patient on who's never been treated before, and why? And I'm going to give the answer first, and then we'll go through the reasoning. For chronic persistent restless legs, which is what this patient has more than 2 or 3 times a week and interfering with the quality of her life, we are now recommending that we start with the drugs called alpha-2 delta calcium channel ligands, which is quite a mouthful. And they really are 3 drugs: gabapentin, a prodrug of gabapentin called gabapentin enacarbil, and pregabalin. We'll come back to all this. And we only use the dopamine agonists, the pramipexole, ropinirole, and rotigotine, if there's some reason that we shouldn't be using the alpha-2 delta channel ligands, we'll come to why, or they've been tried and they're not working. So, you know, if I was giving this talk 5 or 10 years, even 5 years ago, I'd have said start with the dopamine agonists and not the alpha-2 delta ligands. So there has been a clear reversal of recommendations, and this is based on our updated algorithm by the Scientific and Medical Advisory Board of the Foundation, published in 2021. So let's talk about why this change. And we're going to start not with the drugs we are recommending now, the alpha-2 delta ligands, but the drugs which we are saying not always the first line, the dopamine agonists. So let's talk a little bit about dopamine, and I apologize to those of you who know a fair amount about biology and how brains work, but I know there are some who don't, so I'm going to go over this. Let's look at the picture at the bottom. Here in orange is a nerve cell, and nerve cells have this long process called an axon, which end up near another nerve cell. And the way brains work is electrical impulses travel down this long axon until they get to the end of it. And they want to transmit the message, that electrical message, to the next brain cell in blue. But there's a gap. And the way that gap is crossed is not through another electrical impulse, but by the release of a chemical showed by these red triangles in this blue circle. And these chemicals cross in the fluid and bind to proteins on the surface of the next cell. And that starts up another electrical activity in that cell, and another impulse travels on. And these little red triangles, these chemicals, are called neurotransmitters and are absolutely vital for the functioning of the nervous system. There are many neurotransmitters, but the one we're going to emphasize today is a neurotransmitter called dopamine. This neurotransmitter is seen especially in brain cells which control movement, arousal, waking up, and the reward system, the system that gives us pleasure under certain circumstances. Now, the drugs we use that are based on the dopamine system enhance the dopamine, and they work for restless legs. They were first developed for Parkinson's disease, but they work for restless legs. Why do they work for restless legs? After all the years of research, we're not 100% sure, but the problem may be that these protein molecules on the blue cell here, these little orange ones which bind dopamine, we call them receptors, there may be too few of them, and therefore we need more dopamine to bind on the ones that are left, but we're not entirely sure. So what about this drug called levodopa? Some of you may have been on carbidopa, levodopa. The traditional trade name for it is Sinemet. There are many other forms for it. Well, it would be great if we could just give dopamine by mouth, wouldn't it? You just take a pill of dopamine, gets into the brain, and the problem might be solved. But the problem is dopamine doesn't get into the brain when it's taken by mouth. But another chemical called levodopa does enter the brain, so we can give it by mouth. And when it gets into the brain, there are enzymes there that convert it into dopamine. So that's one way that we could increase dopamine in the brain. The other way is we could bluff the brain. And drugs have been developed, which aren't natural substances, called dopamine agonists. They are chemicals that look like dopamine, that are very similar to dopamine, but can enter the brain if it's given by mouth, unlike dopamine, and they bluff the brain into thinking they really are dopamine. So that's just a little primer on how these things work. Let's look at history. Well, we knew about levodopa for Parkinson's disease since the 1960s, but it was really only tried for restless legs in about 1982. It worked beautifully. And for almost 10 years, we had reasonable success with treating restless legs. I started treating restless legs seriously in about 1991. And by that time, we were in big trouble. Almost all the patients who'd been put on levodopa in the previous decade had developed what we today call augmentation. The first formal reports of it came in 1992, but we were aware of it before. These patients on levodopa were developing more and more symptoms earlier and earlier in the day, and the more levodopa that were given, the worse they became. And the patients were becoming, I don't know if any of you go back that far, but patients were becoming very desperate in the early 1990s, and we had very little we could offer them at that point, except drug holidays, which those of you who have tried it know don't work very well. And then in 1995 came the first report of the use of one of these dopamine agonists, these drugs that look like dopamine and bluff the brain into it. And the first one that was tried was pergolide, and it was wonderful. We wrote up a series early on of our open label experience with pergolide. Another drug became available, cabergoline. And in fact, there was even an earlier one, bromocriptine, but it wasn't much used for restless legs. The reason they're in the strange blue color is that these drugs have one problem. They can damage the lungs and the heart, a process called fibrosis. And because of that, They were used with very great care. But then, thankfully, in 1999, two new drugs were developed, also dopamine agonists, but what we call non-ergot dopamine agonists that can't damage the lungs or the heart. So cabergoline, pergolide fell out of use. In fact, pergolide is no longer even available, and we moved our patients onto pramipexole and ropinirole. And finally, in 2004, the third of these non-ergot drugs, rotigotine, which is given by a skin patch, became available. And these three drugs here, pramipexole, ropinirole, and rotigotine, are the three mainstays of dopamine agonists still used 20 years later for restless legs. But of course, we ran into trouble after the original honeymoon period with pergolide and the original use of pramipexole and ropinirole. So why don't we start with them in most patients? Well, as most of you know, the main problem is the risk of augmentation, which we saw with levodopa. We hoped wouldn't happen with the dopamine agonists, but regrettably it does. So what is augmentation? It's the development of worsening restless legs with increasing doses of dopamine medication. The most characteristic feature is earlier onset symptoms, and the sort of way I explain it to my patients is I say, okay, you take the medication 2 hours before bed. It's wonderful. You get the best night of your life. And then 9 months later or so, you start getting it in the evening. Never had it then before. So your doctor gives you a little more at 5 p.m. and it's wonderful. And then a month later, it starts happening in the afternoon, and it just moves earlier and earlier. It may also spread from the legs to the arms or the trunk. And then it stops working at night, or at least breakthrough occurs during the night. It used to last all night. Now at 2 in the morning, you're waking with restless legs. And the more medication your doctors give, the worse all this becomes instead of better. What is the risk of this? Well, it's somewhere between 40 and 70% over 10 years. That's based on 2 studies. Here's the first one, which comes from the Hopkins group. Chris Early is the leader of that group. And I want you to concentrate on the dark blue line, which goes lower and lower down. This is the percentage of patients without augmentation for 10 years on pramipexole or pergolide. As you can see, the percentage of patients without augmentation gets less and less and less and less, and it works out to about a 70% number ended up with augmentation over 10 years. Here's our study from Mayo. Dr. Melissa Lipford, who was my fellow at the time, did the work on this. We had 50 patients. We followed them for 10 years, and about 40% of ours developed augmentation. Interestingly, ours wasn't a steady work, more and more and more. Most of ours developed in the first 3.5 years. It's not quite clear why the studies are a little different, but the bottom line is pramipexole, ropinirole, probably a 40 to 70% risk of augmentation, which is high. However, on the other side of it, it means there's at least 30% of patients who use them long-term without augmentation. So some people get away with it. Now, what about rotigotine, the patch? I'm talking mainly with generic names because that's what I'm supposed to, but the patch is known as Nupro. There's one very good 5-year study, and the augmentation rate was also high after 5 years, 36%, but most of those patients did not need to discontinue it. Only 4% did, which suggests that maybe the augmentation was milder with the patch than with the 2 oral agents. And we still base our logic, as you'll see, on that sometimes we'll use the patch if we worry about augmentation. Doesn't always work. Some of the patients do develop augmentation as well. All right, so what are the risk factors for augmentation if we do use the dopamine drug? The most important, that's why I've made it in red, is too high a dose. The main reason people go rapidly into augmentation is because the dose has got too high. However, probably the longer they've had symptoms, greater risk. If their iron stores are low, there's a greater risk. For more severe restless legs before starting treatment, there's a greater risk. And levodopa was probably a greater risk than the dopamine agonists. We had to stop using that altogether because, almost 80 or 90% of the people got augmentation. And it's possible that rotigotine has less augmentation than the 2 oral agents, pramipexole and ropinirole. Well, the second problem with the dopamine agonists can be very troublesome, but is a little less frequent, and that's the impulse control disorders. We did a control study of this some years ago. Dr. Jason Cornelius, my fellow at the time, did the work on this. So we looked for impulse control disorders in our dopamine agonist patients. And those are patients who started pathologically gambling, compulsively shopping, or sometimes looking for sex on the internet. This is sometimes mild and sometimes horribly severe. People who never gambled before start going to casinos or gambling online or shopping with totally unnecessary things. I'm talking about some extreme cases. We've had people who've lost $100,000 doing these things. We found that 17% of our patients develop impulse control disorders. Other open label studies have suggested it's less, 6%. And it's possible that our patients were on higher doses at that time than some of these studies. So it may be less than 17%, but it's still not insignificant. It doesn't mean we can't use the drugs. I warn every patient about them when we start. I ask them about it every time they come for a return visit. And we know that if we stop the drug, the impulse control problems disappear overnight. My patients can't believe it. I mean, that this terrible urge just melts away if you stop the drug. But it doesn't mean we want them to have it in the first place, and we try hard to avoid it. All right, are there other side effects from the dopamine agonists? Yes, but mild, most often in the higher doses we use with Parkinson's disease. Some people get lightheaded or get nauseous, some nasal congestion, occasional leg swelling, nightmares. If it's used during the day, sleepiness can develop. But really, these, for most people, are very mild or non-existent in the low doses we use. The only one that I just want to comment on is the rotigotine Nupro patch. Most people get a redness of the skin from the patch, but if they move it from site to site each day, usually that goes away. 30 to 60% of patients will get this. If there's breakdown of the skin, obviously we can't use the drug. So how are we doing on this change? Are we using less dopamine agonists? Here's a study from John Winkelman at Harvard, published last year, and he looked at a US national prescription database, 670,000 patients with restless legs, and some of you may well be on this database. Still, at this time, when he did the study, 59% of the patients were still using dopamine agonists. That's high. And more worrisome, almost 20% of the patients in this database were using the amount of dopamine agonists they were using was greater than the recommended maximum doses. So we've got a way to go. So let's change direction. If we're not going to start with these drugs in most patients, how well do the alpha-2 delta ligands work? Gabapentin, pregabalin, and gabapentin enacarbil. So let's look at that history. The first open label short reports of gabapentin came in 1996. I remember them very well, and we were a little skeptical. Does this work at all? But small controlled trials came in 2001 and 2002. Actually, gabapentin itself has never been tested in a large controlled trial, but the prodrug that gets converted to gabapentin, called gabapentin enacarbil, has undergone big controlled trials, which were successful, shown that it works. And then the third drug, pregabalin, came in, and controlled trials were positive in 2010. And then a very important controlled trial I'm going to show you now was done in 2014. It was the first and only controlled trial in which one of the alpha-2 delta ligands was actually compared to a dopamine agonist. So how do they work? Well, we don't really know. We know they were first developed, by the way, to treat epilepsy, but they're not terribly good drugs for epilepsy. They certainly help chronic pain, which is different from restless legs, of course. We know they reduce the release of a number of neurotransmitters from neurons, but the exact way they work in restless legs, we're still uncertain about. But that doesn't matter, they do work. So gabapentin is the cheapest. One of the problems is that when you go above a dose of 600 milligrams a day, the amount that you take by mouth, it doesn't always correlate with the amount that gets into the body, because the absorption from your intestines into the body becomes very variable. So when we say, okay, you're on 900 milligrams gabapentin, we don't know for any one person exactly how much of that's getting into the body. Gabapentin enacarbil was developed to try and avoid that problem, but it's more expensive. It's a prodrug of gabapentin. It gets easily into the body and then is converted to gabapentin slowly and probably lasts most of 24 hours. The third one is pregabalin, and this is the one that had that very interesting trial comparing it to pramipexole, and I want to tell you a bit about that. So there were 4 groups of subjects tested with restless legs. The first group was given pregabalin at 300 milligrams a day, a very standard dose. The second group was given pramipexole at 0.25 milligrams a day. The third, pramipexole at 0.5 milligrams a day. And the fourth one was given placebo, sugar pill. The first 12 weeks of the trial were double-blind. Nobody knew what they had. And this is your International Restless Legs scale. High is bad, low is good. So as the first 12 weeks continued, the green one here, which is the pregabalin, almost immediately in the first 2 weeks, things improved and continued to improve. Pramipexole 0.5 milligrams, the same thing happened, but interestingly, the placebo also improved. Remember that placebo effect, but not as much as these. And pramipexole 0.25 milligrams didn't do any better than placebo in this group. Interesting. After 12 weeks, the double-blind control part stopped, the placebo group dropped out, but the others continued. They learned what drug they were on, and the results were the same up to a year. Pregabalin worked, and to a certain extent, the pramipexoles worked as well. In fact, the statistics were such that pregabalin worked as well as 0.5 milligrams pramipexole, maybe a little better, but that wasn't clear. This is just another way of doing the same thing. Good, high is good. Again, pregabalin worked and continued to work, so did 0.5 milligrams. Pramipexole, the 0.25, a little less good, and the placebo also improved, but that was the weakest. So it works. It's effective versus placebo. About 71% of the patients on pregabalin felt they were very much improved or much improved. There was no augmentation after 52 weeks. It's certainly no worse than pramipexole at 0.5 milligrams, maybe superior. But the problem was that despite no augmentation, other side effects were noted. Some patients got dizzy, sleepy, fatigued, and there were an occasional patient with suicidal ideation, which is concerning, obviously. Now, I'm going to show you some doses, but I want to be very clear. This is just for those of you on the drug to see where you might be. This is not for you to in any way change your doses. That can only be done working with your personal physician. Every patient is different, how much medications they need. This is just to give you a general guideline. For pregabalin, the usual effective dose is 300 milligrams a day. Gabapentin usually between 900 and 1200 milligrams, and there's really only one dose for the gabapentin enacarbil, 600 milligrams once a day. There are some higher doses you can go to, and we always start low, especially in older patients, and build up the numbers. These medications leave the body through the kidneys. That's what renal excretion means. So if one has kidney failure, one either can't use them or have to reduce the dose. The other thing I'd just point out, a lot of physicians use these drugs for pain and give them 3 times a day, which is very reasonable. But for restless legs, very often they only have to be given once a day. And a lot of physicians aren't aware of that and think it has to be given 3 times a day. That's not so. All right, let's go back to the bad side. What are the side effects? Well, in younger people, they're often none at all, and many older people tolerate it well. But a lot of older people do get side effects, and some younger ones do as well. If it's taken during the day, there may be daytime drowsiness, not usually a big problem here because we usually give it at night. Dizziness, unsteadiness, and a strange mental fogging may occur, and if that happens, we can't go higher in the dose. Regrettably, these drugs are associated with weight gain. They also can worsen depression if it's present, and some patients with more severe depression can get suicidal ideation, so we don't like it in patients with active or severe depression. There's some indication that it depresses breathing. I've never seen this as a problem in people with healthy lungs. But people who have lung disease, such as COPD, we've got to be careful with these drugs. There is an abuse potential for them. I've never seen that in my restless legs patients, but there are good reports of some abuse of these drugs, so we've got to be careful with them. On the other hand, there is none of that augmentation that we see with the dopamine agonists and no impulse control disorders. They may also be helpful if a person has a pain problem in addition to restless legs. Remember, they also help chronic pain, and they also sometimes help anxiety. Even though they worsen depression, interestingly, they may actually improve anxiety. So we said these are the drugs to start with. When don't we start with them? Well, a person who has marked weight, high weights, in the obesity range, we're a little more careful and discuss it with them because there's regrettably a chance the weight can go higher up. If they've got moderate to severe depression, again, I'm concerned about using this. If they've already got a disorder where they're unstable walking, we're concerned. Clearly, if they've got respiratory failure, breathing problems, we don't particularly want to add this drug, or a history of substance use disorder. But for others, we'll start with this drug. When will we start a dopamine agonist? Well, if they've got these contraindications, if there's a reason for not using alpha-2 delta ligands, of course we'll use a dopamine agonist. Or we use the alpha-2 delta ligand and some of these side effects develop and the patient says, I can't take the drug anymore. We'll convert to a dopamine agonist. Or we've used the alpha-2 delta ligands and they're not working adequately. And remember, they're not miracle drugs. None of them are miracle drugs. There'll always be people in which they don't work adequately. We've pushed it up to the highest dose that we're comfortable with and the patient can tolerate it. They're not working. We'll then change to a dopamine agonist. So I don't want to give the impression we don't use them anymore, but where possible, we use them as a second line agent. If we use them, and again, these are just guidelines, but I really want to emphasize here the maximum dose. For Parkinson's disease, we use these drugs in vastly higher doses. But for restless legs, we really shouldn't, in most patients, go above 0.5 milligrams a day pramipexole. I think 2 milligrams, but it's FDA approved at 4 milligrams, or the 3 milligram patch, because it's when we go higher and higher and higher on these doses that augmentation becomes more of a problem. Pramipexole is excreted by the kidneys. So again, if one has kidney failure, probably ropinirole or rotigotine are a better drug. They are excreted in the liver. So if you've got liver failure, then probably pramipexole is a better drug. And one other little trick which is important is they take about 2 hours to get into the body. That is the 2 ones we take by mouth, pramipexole and ropinirole. I had a patient just last week who was taking it at just as she went to bed at 11 p.m. and she says, you know, it's not working because I have restless legs between 11 and almost 1. Then I fall asleep and I'm fine the rest of the night. Well, the problem wasn't that it wasn't working, but she was taking it the wrong time. So I asked her to take it at 9 p.m. and I suspect most of her restless legs will melt away. Okay, let's move on now to patient number 2, who regrettably, I suspect many of you will recognize as well. A 55-year-old woman had restless legs from age 19 years, experienced only in bed before sleep at night. 8 years before presentation, pramipexole was prescribed, initially as 0.5 milligrams 2 hours before bed, with good results. But over the years, symptoms worsened and the dose was increased to 0.5 milligrams on waking at 2 p.m. and at 5 p.m. with 2 milligrams before bed for a total daily dose of 3.5 milligrams. Restless legs is now experienced whenever she sits down from 9 a.m. onwards and she has only 3 to 4 hours sleep a night. What should be done? Well, she obviously has very severe augmentation. The first thing we do is we replenish iron stores. This is not a webinar on iron, so I'm not going to go into that at all. And then we do one of 3 things if that doesn't work. If she hasn't tried the rotigotine patch, we substitute that. Or if she hasn't tried gabapentin or pregabalin, we add that in and then try reduce the dopamine agonist. Or if she's done that and hasn't worked or there's side effects, we substitute an opioid and slowly wean the dopamine agonist. Let's consider each of those interventions. If we change to rotigotine patch, it's very important for your doctors to know how to do that. If the patient, let's say, is on 0.5 milligrams pramipexole and has had augmentation, you get it sometimes at that lower level, stop the pramipexole, put on 3 milligrams rotigotine. But if she's on 3.5 milligrams pramipexole, 7 times the maximum dose we recommend, or even 4 times, and you stop your pramipexole immediately and substitute 3 milligrams rotigotine, you're going to have a drastic drop in your dopamine levels in your brain. It's going to go down to 1/7 of what it was overnight. Terrible, terrible restless legs develops. And of course, the patient says this patch is totally useless. It's made it worse. But the patch hasn't made it worse. What's happened was you've got this drop in levels. So what you really need, what your doctors really need to do is put in the 3 milligram patch and then slowly, slowly, slowly reduce the pramipexole over some months rather than abruptly stopping it. And this is just to show you that the 3 milligram maximum dose patch is only equivalent to 0.5 milligrams pramipexole or 2 milligrams ropinirole. The second thing that can be done is to introduce gabapentin or pregabalin. Now, again, this can be done wrongly. Some doctors simply say, stop your pramipexole and start gabapentin. Disastrous. You can't abruptly stop a high-dose dopamine agonist. So we first titrate up the gabapentin to 900 milligrams, pregabalin to 300 milligrams over a week or so. Then keep them on that for another week and then slowly reduce the dopamine agonist. Now, big question, how fast can you do it? Well, it depends how high you are in the dose. It depends on the patient wishes. I do have some patients who say, doctor, I just want to cold turkey it. I want to get off. I want to stop. I discourage that, but some people do it and some people can do it successfully. And obviously the severity of the withdrawal symptoms, if we're going too fast, we have to go slower. And I recommend that if the daily dose of pramipexole is 1 milligram or less, you can go down at about 0.25 milligrams a month. If it's higher than that, 0.5 milligrams a month, though some patients can tolerate faster withdrawal. So our patient on 3.5 milligrams, I would take down at 0.5 milligrams a month, which would be about 5 months to get down to 1 milligram, and then another 3 months or so to get off altogether, probably over 7 or 8 months, though we might try and go a little faster. Be aware that many of you who might be on these high doses that we try to get down will never be able to get it off altogether. And you will need to remain on a very low dose of maintenance dopamine agonist, whatever else we do. Okay, why can't we do it faster? Well, this is the dopamine agonist withdrawal syndrome. If we go too fast, cold turkey it, many people get anxious. They can get depression, irritable, agitation, panic attacks, profound insomnia with worsening restless legs, craving for the dopamine agonist, and in severe cases, sweating, flushing, nausea, and lightheadedness. How common is this? Here's a study of patients who were rapidly withdrawn from dopamine agonists with Parkinson's disease. That's different, but up to 20% got this withdrawal syndrome. Here's another study where they got the patients off. How long before the dopamine agonist withdrawal symptoms recovered? It took a long time. In 61 patients, less than 6 months, but almost a quarter of the patients, it took more than a year before they got over the withdrawal. And 15%, it was so severe, they just needed to start the drug again. It has been formally reported in restless legs. We know it happens, but we don't have a strong feeling of how frequently. The third approach is to substitute an opioid. And again, this webinar is not on opioids, but again, first build the opioid up to the right level, then slowly bring down the dopamine agonist, and they're well tolerated and effective. So how well are opioids doing? This is a study of the National Restless Legs Opioid Registry run by John Winkelman in Harvard, 500 patients, and he followed them after a year. These are patients who around the country were put on opioids for restless legs. Some of you may well be in this registry. The amount used was not high, equivalent to 20 milligrams oxycodone daily on the whole. Some people needed to increase the dose, some decreased it, and with those who did increase it, it was for good reasons. Opioid was also used for pain unrelated to restless legs. They'd been using it less than a year and hadn't found a stable dose yet. They were changed to methadone, which requires a slightly higher dose, or they were coming off the dopamine agonist. Side effect, about half the patients developed constipation, but most people can control it. Some got drowsy on the opioids, but more had decreased drowsiness because for the first time in months, they were getting proper sleep at night. Itch and sweating was a problem as well. We now have 2-year follow-up, and the results are very similar. And Here's a study of real-world management of augmentation, also from the Winkelmann group. And they looked at 63 patients who presented with augmentation to them. Those patients had been on dopamine agonists for 11 years. They were on an average of 1.2 milligrams high. Remember, we don't want to go above 0.5. And what happened? Well, 75% of them they helped, but 41% of them had to continue low-dose dopamine agonists. They were successful getting them to very low doses of dopamine agonists in 40% with the alpha-2 delta drugs and in 68% with the opioids. And when they looked at the rate they reduced the dopamine agonists, it was very similar to what I'm recommending. It was 0.35 milligrams per month of pramipexole, very, very slowly. So what are the take-home messages? Unless contraindications, alpha-2 delta ligands are first-line therapy for chronic persistent restless legs, chiefly because of augmentation with dopamine agonists and possibly because of impulse control disorders. However, we do still use dopamine agonists if they're contraindications to the alpha-2 delta ligands, if side effects have developed with the use of the alpha-2 delta ligands, or they're unsuccessful. When dopamine agonists are used, physicians should keep the dose low and assess frequently for augmentation, not allowing augmentation to get worse and worse, and certainly not increasing the doses higher and higher. If you need to withdraw dopamine agonists, first you cover with alternative medications in most cases, and then it's slow to avoid dopamine agonist withdrawal syndrome. And low-dose opioids are highly effective in refractory restless legs patients. I know I'm preaching to the choir here, but when I give this talk to physicians, I say, please don't withhold them from appropriate patients. So I know that was a lot of information, but I know many of you are experts in your own way in restless legs. Over the years, seeing multiple doctors and trying to find the best possible approaches. We do not have a perfect solution to restless legs with any of these drugs. New medications are needed. Hopefully they will be developed, but we can do a lot to help when it's managed in an appropriate way. So I hope that's been helpful, and I'm pleased we've got sufficient time to take questions. Thank you.
Well, thank you, Dr. Silber. I'll go ahead and get started on the questions. What are the effects of gabapentin pregabalin on memory and brain function?
Well, most patients manage fine, but some patients, especially older ones, will develop this strange mental fogging. That's how they describe it, or just a poor concentration, attention, memory. When that happens, if it's disabling, obviously we have to reduce the dose or stop the drug. There's no evidence that those drugs cause dementia, but this mental fogging can be very distressing to some patients.
And the next question is it safe to take both ropinirole and gabapentin at the same time?
Yes, it's safe to do that. They're different mechanisms. They don't interact, and some patients do need lower doses of two drugs. Obviously, there are some common side effects. Drowsiness would be the most important one that one would have to watch that didn't develop during the day, but there's no reason not to take the two together if that works best.
Our next question is, once augmentation occurs with Requip, should you try other drugs in that drug category to see if they will provide the same benefit?
Well, that's a very good question. If you've never tried, say, pramipexole, Mirapex, but you've developed augmentation on Requip, should you try Mirapex? We used to say yes, but now we probably say no. Once you've got it on one drug, you might buy some months, but it's going to develop on the other drug. The alternative, of course, is the rotigotine patch, which, as I said, thought to have a slightly lower frequency of augmentation or milder augmentation, possibly because it's the drug's released slowly over the course of 24 hours. So it would be fine to try the rotigotine patch, watching carefully for augmentation, but generally I try to avoid putting a ropinirole patient with augmentation on pramipexole or vice versa.
The next question is, what impact does age have on medication effectiveness?
Well, the first thing, of course, is that age, all side effects can worsen with age. So the first thing is not effectiveness, more important, it's side effects. I don't think there's a specific failure of the drug related to age. It may be related to duration of use of the drug, that augmentation becomes more and more common, and sometimes severity of restless legs increases with age. But I don't think drugs wear off as the effect wears off, particularly as we get older. I have a number of patients on opioids in their 80s. We're very careful with it, but they still seem to be effective.
Here's one that I see a lot too, is can I switch between ropinirole and pregabalin every 6 months, 12 months, 18 months to prevent augmentation?
We don't have a huge amount of data about drug holidays or swapping drugs. We think it's probably not particularly effective. It's very difficult to do that. I mean, are you going to just stop the dopamine agonist or wean it and overlap it? Often the patients who've been on dopamine agonists, some of them seem to not respond as well sometimes to the gabapentin drug. So you're risking loss of control. And the evidence isn't there that that type of approach is going to reduce the risk of augmentation. I don't think it's dangerous to do that, but it might be uncomfortable with recurrence of restless legs and difficult to get back into control. And I don't think we've got great evidence. It makes some logical sense, but I don't think there's great evidence that it's going to reduce augmentation. It's just not been an approach that I've used very much over the years.
Next question is, does the ability of these medications to treat symptoms of RS tell us about the root cause of the disease?
Yes, that's a good question. Yes and no. I mean, we know that the dopamine system is clearly involved in restless legs, maybe at the dopamine receptor level. There's hypotheses that the iron is necessary for certain steps in dopamine metabolism and for the receptor, and it's possible that we've got a problem with transport of iron into the brain. But that's about as far as it goes there. The gabapentin group, the alpha-2 delta ligands, we don't really know quite how they work in restless legs, and I'm not sure we've had any great insights into understanding the underlying problems from that group.
Next question is, augmentation inevitable with ropinirole or any of the dopamine agonists?
No, it is not inevitable at all. You will recall I showed you the Hopkins study, which showed with pramipexole 70% risk over 10 years, and our study from Mayo suggesting a 40% risk. So even if you take the Hopkins study, there was still 30% of patients who used it for 10 years and did not develop augmentation. So no, it's not inevitable by any means. And I have many patients, not many, but certainly some patients who've used low doses for years and years without difficulty.
What should a person do who has augmentation with dopamine agonists but is allergic to gabapentin and related drugs?
Okay, so if you can't use gabapentin or related drugs because of allergy or side effects, then we look carefully at the iron status and replenish that. If that's been done, then we would probably, again, I can't comment on individual patients, but we'd consider the use of opioids at that point.
Okay. What is the best method to go from ropinirole to an alpha-2 delta ligand?
Okay, so again, this is an important question. We first introduce the alpha-2 delta ligand without touching the ropinirole, build it up to a dose we think will be therapeutic, wait maybe a week, and then slowly reduce the dopamine agonist over months, depending on how high it was, of course, to start with.
Are long-acting dopamine agonists, extended release ones, better for preventing augmentation?
Well, we are not really sure. Rotigotine may have a slightly, that's the patch, Neupro patch, a reduced rate of augmentation, or it may be milder. So, you know, if that was a major concern, it wouldn't be unreasonable to start on rotigotine, though it is more expensive. There are some controlled release forms of pramipexole, for instance. There's one study from Europe suggesting maybe it's better for augmentation, but we've very little experience in the US with using the controlled release pramipexole or ropinirole for restless legs.
Okay. Our next question is, can the augmentation caused by the medication, meaning dopamine agonists, be reduced or by reducing the amount of medication but not eliminating it?
Yes, that is a possible step. We would slowly reduce it, very slowly, and sometimes we get to a point in which it goes away, and some people get away without introducing something else. Remember, I was talking about severe augmentation. If we have mild augmentation early on, we might try and reduce the dose and see if we can get away with it. As I said, with severe augmentation, sometimes you can't get the person off the drug altogether anyway, and you end up on 0.25 milligrams pramipexole in addition to whatever else one uses.
So would this be an instance where you might do a split dosing, Mike?
Well, let's think about that a moment. If somebody is on 0.25 milligrams pramipexole, nice low dose, and they're starting to get a little augmentation, say it's working so well at night, I don't want to stop it. I might introduce another 0.125 or 0.25 at 5 in the afternoon, watching very carefully that it doesn't spread earlier and that the maximum daily dose doesn't go above 0.5 milligrams. If they're on 0.5 milligrams and they've got some augmentation a little earlier in the day, I might split the dose, give them 0.25 2 hours before bed and 0.25 at 5 p.m. Same dose, not above the maximum, and sometimes that works. Generally, we're buying time rather than getting rid of it altogether. But yes, that's a good question, and certainly for milder augmentation, that's sometimes the approach we take.
So it's something that you have to really work with your patient with, like, have this dialogue. And so you might try something for a while, it may not work, but you'll have to come back and try something else. So there's not like a one size fits all approach to managing augmentation, even in its early stages. You kind of sort of have to go with the patient's symptoms.
I think so, and the patient's wishes. Some people I've read all about augmentation. Now I'm starting to get it. Get me off this drug right away. I don't want to take it anymore. Others say, you know, it's working so well. Can't we just try a little longer? And we certainly do that. So yes, it's each person's individual. Management is always individual. These are all guidelines. It's the physician working with the individual patient.
So I'm going to ask you a question. We're getting a lot of questions about where do you find an RLS expert to manage, you know, a difficult case of RLS?
Yes, that's always a tricky question, isn't it? I would look for the RLS quality care centers. I'd look for the foundation's list of experts who they have available in your area. Clearly, the quality care centers, of which there not all that many in the country, cannot manage every patient with severe or worrying RLS. And we try our best to educate neurologists and sleep physicians about it. I think work with the foundation to find an expert in your area as much as possible.
And if you need to reach out, please email us at info@rls.org and we can help you find an RLS doctor to help you. Next question, are dopamine agonists appropriate for RLS in any situation?
Well, as we mentioned, it would not be our first line. The situation in which they are appropriate are patients who cannot use the alpha-2 delta ligands because of contraindications, or they've developed side effects, or it's not working. Those would be the patients we'd use dopamine agonists on.
Should I increase my dose of pramipexole if my symptoms are worsening, or just tough it out?
You shouldn't do either. You certainly shouldn't increase by yourself. You should discuss it with your prescribing doctor and determine whether augmentation is happening. I mean, sometimes it isn't. There's no spread early in the day. There's no spread to the arms, but for some reason, it's not working well enough at night and you're below the maximum dose, and then sometimes an increase is appropriate. But in many cases, when I hear that story, it's getting worse. It usually, but not always, means augmentation. Your doctor can check your iron levels, see if you've started any new drugs which could worsen restless legs, and it needs an assessment. If restless legs is getting worse on dopamine agonists, one should neither tough it out nor by yourself increase the dose, but refer to your specialist and see what best approach to take.
So we're getting some questions in the chat box. People are wanting to know, is it possible, how hard is it to go from a dopamine agonist to an alpha-2 delta ligand as a solo therapy?
It's tough sometimes if you've got augmentation on a high dose. It's tough. You've got to withdraw the dopamine agonist slowly, get up to the right dose. And there is some data, not terribly strong, which suggests that people on high-dose dopamine agonists may not respond as well to the alpha-2 delta ligands compared to people starting it who've never been on drugs before. Nevertheless, if you haven't been on an alpha-2 delta ligand ever or haven't properly tried it, when you run into trouble with a dopamine agonist, we do say that's the first group of drugs to try before we go to the opioids. The opioids work well, but nobody wants to be on an opioid if they don't have to, especially the stigma around the country and the difficult getting prescriptions. So we do try that first. But many patients do fail that, and we have to move to the opioids.
And then we have questions about gabapentin and gabapentin and acarbol. What's the difference? And then do you use those ever? Do you ever prescribe both of them at the same time to treat RLS? Are they prescribed as a solo therapy?
Yes, I've never used the two together. It's fine to use gabapentin and acarbol. It's slowly released over 24 hours, so might be better for people getting restless legs all day rather than just at night. It's more expensive, but it is gabapentin. In the end, it's releasing gabapentin into the body.
Mm-hmm. So I see we're getting a lot of questions, and a lot of treatment issues. And one of the things Dr. Silber can't do is give individual treatment response questions, but we're getting a flurry of questions coming in. So I'm just going to kind of walk through and see if there's some that are just you can answer in general.
Sure, I'm happy to answer general ones. Obviously, I can't answer questions on specific patients' problems.
Here's one. How difficult does the National Opioid Registry make it to use opioids for RLS? So I think we might want to give some more background about this study that's ongoing.
Yes, this was a voluntary study. Various RLS experts around the country were asked to tell their patients about the availability of this registry, given information about how to register with it, and 500 patients did indeed say, we'd love to be on this registry and provide information. So they signed up. Dr. John Winkelman in Harvard coordinates it. I believe it's closed now, but those 500 patients are being followed long-term. They fill in questionnaires regularly. They are called to find out how they're doing. And the registry reports at yearly intervals of how well it's doing. It's been, I think, very helpful for us to understand that what we're doing is working, that we've now got good follow-up data on these patients. It's been a very valuable exercise and provides data also to try convince physicians that this is a reasonable therapy, that it's supported by data. I think it's also been used by the foundation for advocacy means in Washington and elsewhere.
That's correct. That's one of the questions that we have is what is the longitudinal data on the use of these low doses of opioids used in the RLS population? And so we're able to, provide them an article with, these findings. So I think everyone who's participated in that, as well as the foundation members who supported this study. So know that, when you make a gift to research, this is the sort of studies that you get to take part in, but also to fund. I do have a question. Can augmentation occur with the alpha-2 delta ligands?
Probably not. There's no good evidence that it does.
Okay, go ahead.
The one opioid where it may occur is tramadol, a low potency opioid. We don't use that often. Probably not with the other opioids. So now and then we see a patient who has a story that sounds like augmentation on opioids, but we're not sure whether that's exactly it. I think the bottom line is generally no, not with the alpha-2 delta ligands or most of the opioids.
Okay. And then last question, are you working on any current RLS research?
Currently, we're not trying any new drugs at Mayo. We're working on some projects of RLS in certain circumstances, such as after surgery and things like that. But at the moment, we're not personally involved in drug therapy trials of new agents.
All right. Well, thank you so much for your time today. and expertise. This was a really great webinar. I mean, we almost had 800 people, sign up to attend. So we know we're going to have a lot of requests for the link to the playback, but we will post it on the member portal within 24 hours because we have to download it and re-upload it. But I wanted to remind everyone our next webinar is on Wednesday, April 26th at 1 p.m. Central. Dr. Kathy Richard will be discussing aging with RLS. So I'd like to thank everyone for joining us today and have a great afternoon.
Thank you for inviting me.
Thank you, Dr. Silber.